It's the Very Large Database of Lipids, or VLDL-2 Study, aptly named not only because it's VLDL2, but it's a clinical sample of 1.3 million adults, so it is truly a very large database of lipids. And I am with Seth Martin and Stephen Jones from Johns Hopkins University, Baltimore, and we have new guidelines, which we'll get to in a moment, but this paper just appearing in JACC. Tell me a little bit about the VLDL2 study.
The study really is quite simple. We focused on non-HDL cholesterol in comparison to LDL cholesterol, and basically because they're in a little bit of different scales with milligrams per deciliter, we just classified on population percentile basis. So they're basically compared an equivalent parameter or unit for each, and just looked in the population, how do those two compare, and how do, if we were to classify patients based on population percentile cutoffs versus the typical guidelines cutoff of 30 milligrams per deciliter higher, how do those things compare, and how could that potentially impact the treatment of patients? So it was a paper that was focused on non-HDL cholesterol, its percentiles, and treatment implications.
So what did you find?
Well, the interesting part is, first, what many of us suspected, that the arbitrary addition of 30 milligrams per deciliter to LDL cholesterol is not necessarily the correct additive factor to get an equivalent population percentile in non-HDL cholesterol. And this is because the VLDL cholesterol contribution to non-HDL changes dependent on triglycerides. So what we found was that the actual values, probably close for most of the patients, particularly in the secondary prevention range, yielded a non-HDL cholesterol of about 93 milligrams per deciliter. And I think the important take-home message there was, at first, that seems like a very small difference between 30, which would yield 100 milligrams per deciliter, but we reclassified a substantial number of people to different therapeutic goals based on that really small difference based on the population percentile assignments. So it was, I think, a pretty important result. We think it still remains important even in the setting of the new guideline release. And I think it's important to understand the contribution of the triglyceride-rich lipoproteins to the non-HDL.
Now, the current guidelines, as of right now, have some different recommendations. Have, no targets, for example, just aggressive statin therapy. Is that enough, or do you think there needs to be something more when the guidelines people get together to start looking at the next one?
Well, I'd be interested to hear what Dr. Martin thinks. My feeling is that there's a logical problem with the way the guideline's written, where it essentially identifies people with very high LDL that reach the nominal screening criterion for non-HDL cholesterol at 190 milligrams per deciliter to have a diagnosis of familial hypercholesterolemia. Once you achieve that cut point, then you have treatment targets. Below that, you don't. And I think probably the saving grace is that the willingness to give potent statins. So if someone, for example, had 180 milligram per deciliter non-HDL and was indeed at a secondary prevention risk, a typical potent statin would give roughly a reduction of 50% in the LDL cholesterol or non-HDL cholesterol. That would probably get patients down roughly into what would be, by antiquated view these days, an appropriate on-treatment LDL cholesterol level. So pragmatically, it probably is going to still net appropriate treatment by old criteria using the new guideline. I think it potentially sort of throws 50 years of biology under the bus, simply saying that we're not going to use targets, we're not going to use on-treatment lipoprotein burden to assess adequacy of treatment. I think we have a very direct biological causal relationship with ApoB-containing lipoproteins, and I think my opinion, and I think it's the opinion of others, that's not solely my opinion, is that it might have been a little premature to throw the targets out at this point. But I think this will be discussed in the literature, and I think meetings like this will have ample opportunity for our various colleagues to get together and decide what we think about it now in the light of the new guideline.
So you think this is still an important issue that needs to be talked about?
Yeah, absolutely. I think we have to place the new guidelines in the context of existing guidelines around the world, and there's still targets in Europe and Canada and also other U.S. guidelines that just weren't released by recently. But if you look at other guidelines in the U.S., including recent guidelines from the ACCHA for secondary prevention, these targets are in there. So I think we have to take these new guidelines in the context of all those others and really try to understand what is the best evidence. I hope that the type of research we've done here will be considered by the next update to this release of the 2003 cholesterol report, because unfortunately the total body of medical literature wasn't included in this guideline.
Which is an extremely important point. I mean, you have to realize that they had a cutoff in 2011, I believe. So anything that's been published 2012, 2013 is not going to be there. Do you think your paper should be considered when they come back and have to look at this issue again for another iteration?
Yeah, the obvious answer to that question is yes. But I think the broader impact is not just including our paper or other papers we've written from the VLDL database, which would be considered observational data. I think the very narrow scope of the current guideline process to pretty much restrict it to review of papers which are randomized controlled trials really is, in my opinion, not consistent with the spirit of writing guidelines, because guideline has to include, by definition, has to include expert opinion. Right. Because we simply don't have an RCT to handle every single clinical scenario that comes up in managing patients. So I think to offer practicing physicians, a document that essentially is going to say we're going to restrict it just to RCT data and not try to expand it to the broader array of situations that occurred in practice, which I think ATP3 did pretty well. Personally, I think we should have taken ATP3, identified many of the shortcomings of ATP3 that became very evident over the 10 years or so of its lifetime, and built on ATP3 rather than essentially start from scratch and come up with an entirely and frankly pretty radically different approach. It's a major departure from what physicians are familiar with.
Since we've wandered in a number of different directions, what's the bottom line clinical message you want people to take away from the VLDL-2 trial?
I want clinicians to take away that LDL is very important. We're all comfortable with it, but non-HDL is also important and can add information. I think that probably it's best to view them both in tandem, and even small differences at a population level can lead to a lot of reclassifications of patients, and there could be a lot of patients that would be treated differently were non-HDL considered, and also were guidelines written that takes into account the population percentiles as opposed to just a fixed, somewhat arbitrary milligram per deciliter comparison between the two.
So for this particular paper, we're looking at the issue of JACC that is dated November 19th, 26th. Please go read the paper and a variety of others that we're covering here at the American Heart Association meeting. For Cardiol Source World News, I'm Rick McGuire.